So the drug development pipeline for Huntington's disease is long and complex. You have to identify targets, find and make molecules. You then test them in cells and animals. You then do clinical trials in humans. And I'm going to tell you about a phase 1/2 study, and Scott's going to tell you about a prospective phase 3. So Ed presented on Friday. A gene makes a message, makes a protein, and that makes us us. In Huntington's disease, the HD gene makes the HD message, which makes the HD protein. And I'm going to talk to you about Huntington lowering, which reduces the amount of the toxic disease-causing protein. And I'm going to talk to you about antisense oligonucleotide therapy, and I'm going to shorten it to ASO. So an ASO is a single strand of chemically modified DNA, and it's been very specifically designed to bind to the Huntington message, the mRNA, and that binding leads to degradation of the Huntington message, which leads to less of the toxic disease-causing protein being made. ASOs are highly diffusible. You can titrate the dose. They're stable because they're chemically modified, and that chemical modification means that single strand of modified DNA is stable. And importantly, they're reversible. Antisense drugs don't cross the blood-brain barrier, so they have to be delivered directly into the central nervous system. And that means they have to be injected into the spinal fluid via an intrathecal injection. And this is the injection, it's a lumbar puncture, it's an injection into the spinal fluid, and it's commonly called a spinal tap, and Ed talked about this on Friday. The drug is injected into the lumbar region, where, this is a schematic, it travels to the brain where it is needed for its action. So Ionis Pharmaceuticals started work in 2005 and did 10 years of careful preclinical work before going to the clinic. And the questions were, can an ASO be designed that potently and specifically reduces Huntington mRNA and protein and affects phenotypic improvements in animal models? Is a non-allele selective approach to treat everyone viable? And is the ASO safe in preclinical toxicology studies? And does intrathecally delivered ASO distribute well to brain regions that we know are affected in Huntington's disease? And here you can see the ASO is infused into the CSF in non-human primates, and it's taken up equally in neurons and non-neuronal cells. And this is important because these are the cells that we need the ASO to get into to target its action. Does the ASO distribute in the CNS to where we need it to be? Another important question. And this is a slide showing Huntington RNA and protein reduction throughout the non-human primate CNS. And here on the y-axis is Huntington levels, and here on the x-axis is brain regions. This is RNA and protein. 4 doses of the ASO at 1 month intervals. And the samples were taken 1 week after the last dose. And you can see here about 80% lowering in the frontal cortex and occipital cortex, key regions affected in Huntington's disease. About 50% lowering in the deep structures, the caudate and the thalamus, and about 80% lowering in the hippocampus. So because I want to tell you the trial results, I'm going to give you a rapid preclinical summary. The ASOs improve phenotype and survival in HD animal models. Then tested in several large animal models which showed distribution to key regions we know are affected in HD. There were no adverse treatment-related histological changes. There were no changes in standard clinical pathology or safety pharmacology. There was no evidence of genetic toxicity or reproductive toxicity. There was no evidence of toxicity resulting from non-allele-specific production of Huntington mRNA or protein. With chronic administration in non-human primates up to 15 months, there were no new adverse findings. And the data supported a wide safety margin for dosing in the clinic. So the major questions again. Can the ASO be designed that potently and specifically reduces Huntington? Yes. Is a non-allele specific approach viable? Yes. Ionis pursued a non-allele selective and an allele selective approach in parallel. They went forward with a non-allele selective approach because it had a better therapeutic potential from their data. Is the ASO safe in preclinical toxicology studies? Yes. And does an intrathecally delivered ASO distribute well to the brain regions that we know are affected in Huntington's disease? Yes. 4 years ago, I stood up at EHDN in Barcelona in September and announced that we would be doing this trial. And now I'm going to be here telling you the trial results. The first successful Huntington-lowering clinical drug trial. The major objectives, the primary objective was safety and tolerability of the ASO. The secondary objective was how long does the ASO last or stay around in CSF, the pharmacokinetics. And the exploratory objectives is how long does the ASO stay around in plasma, pharmacokinetics in plasma, and does the ASO engage with its target, the mutant Huntington transcript, and does it lower the mutant Huntington protein? We also had Huntington's clinical endpoints, and they were included for safety. They weren't included for efficacy because this was a short, small, early phase study. So this is the design. It's a phase 1b, 2a placebo-controlled study in patients with early Huntington's disease. Multiple doses were given intrathecally by a lumbar puncture bolus injection. Conducted at 9 study sites worldwide in UK, Germany, and Canada, and sponsored by Ionis in partnership with Roche. Subjects had 6 weeks of screening. They were randomized 3-to-1 active to placebo, and then dosed at day 1, 29, 57, and 85. 3 months of dosing, 4 months of follow-up, 7 months in total. This is the study drug dosing and CSF sample collection, and I'll talk you through this. Subjects come in on day 1, they have a lumbar puncture, and CSF is taken off. That's the baseline sample. They're then given the drug or placebo. They come at day 29, 57, 85. And these are the samples at trough, 1 month after the prior dose. Subjects also had a lumbar puncture at day 113 or day 141, and they were randomized to either of those time points. And the reason for that is that we didn't want to do too many unnecessary lumbar punctures. So for the analysis, I'm going to show you the change from baseline to the last available trough sample. But first, study drug doses. Cohort A, 10 milligrams or placebo. Then cohort B, 30 milligrams or placebo. Cohort C, 60 milligrams or placebo. Cohort D, 90 milligrams or placebo. And cohort E, 120 milligrams or placebo. We had an independent data safety monitoring board that was reviewed unblinded data between each of the cohorts. And then they told us whether we could go to the next dosing cohort with an increasing dose in a multiple ascending dose design. These are the demographics. This is the table of the demographics of the trial participants. They had stage 1 Huntington's disease. The age, gender, and CAG repeats was well matched. They were in their 40s, well matched for gender, well matched for CAG. 34 subjects got active, 12 subjects got placebo. Primary objective, safety. The ASO was well tolerated. No participants discontinued from the study, which for a first-in-man study with a relatively invasive delivery procedure was impressive. Most of our adverse events were mild and considered unrelated to study drug. We had post-lumbar puncture headaches after about 10% of lumbar punctures, but we did not have to give any blood patches. We had no serious adverse events in the active treatment group. We had one in the placebo-treated group, which was an anxious patient who had a mild post-lumbar puncture headache who was hospitalized overnight for observation. We had no clinically meaningful changes in any safety laboratory parameters. The pharmacokinetics showed we had dose-dependent plasma exposure and measurable exposure in CSF over the dosing period. Ed quickly showed you this graph on Friday, and I'm going to talk you through it again. The ASO treatment produced dose-dependent reduction in our target, CSF mutant Huntington. And here, on the y-axis is mutant Huntington protein, percent change from baseline. Here, on the x-axis is the dose level. You can see here there's a very clear dose-dependent lowering of our target, CSF mutant Huntington. At the higher doses, 90 and 120 milligrams, we had a mean lowering of 40% CSF mutant Huntington, with some subjects having up to 60% lowering. Maximum reduction was not reached during the study, and steady state was not reached. Here is the mutant Huntington percent change on the y-axis, and here's study day, 1, 29, 57, 85 dosing days. The grey lines are the individual patients within that cohort. The green thick line is the mean reduction. And you can see the slope of the green line is still going down. And we expect steady state to be reached after 6 months of dosing approximately. An important point is antisense treatment can never eliminate or knock out its target. You will never get knocked out. It will be knocked down, and I think that's an important point. So, CSF mutant Huntington, where is it coming from? And this has been discussed at the meeting in the Huntington lowering session, but I'm going to tell you, Anna Southwell has done beautiful work over a number of years in a number of different animal models of Huntington's disease, where she has shown that mutant Huntington lowering in the brain results in CSF mutant Huntington lowering. She's done a lot of work to show that the lowering of CSF mutant Huntington that we see is coming from the brain. And also, the PTC Therapeutics team and Unicure presented some similar data on Friday. So the preclinical model, the pharmacokinetic pharmacodynamic model, is important. And a lot of work was done on this in non-human primates, and it was highly predictive of the clinical data. So why is it important? Well, it allows us to interpret the observed changes in CSF mutant Huntington. Because we can measure CSF mutant Huntington in patients, but we can't measure brain mutant Huntington because we can't do serial brain biopsies. The clinical data that we had was really aligned with the model predictions. This is a schematic of the predicted CSF Huntington reduction over time for the 120 milligram dose. And the black dots are the actual patient data. So if the preclinical model is correct, 50% of those black dots should sit within that green shaded region, and that's exactly where they sat. And that model can be used to help us interpret the clinical data. A CSF lowering of 40% from the model is predicted to give 55 to 70% lowering in cortical tissue, with 20 to 35% lowering in the caudate, which is a deep structure. 60% lowering in CSF is predicted to give 70 to 85% lowering in the cortex, and 35 to 50% in the caudate, again, the deep structure. And this level of CSF mutant huntingtin reduction that we achieved in the trial, in the higher doses, exceeds the threshold that we know is associated with disease modification in animal models. There are many published and unpublished data showing that huntingtin lowering and mutant huntingtin lowering improves phenotype in HD animal models. And much of the data shows that between 30 and 50% lowering in cortex produces benefit. And importantly, pharmacologically relevant doses were tested in this study because we got lowering of our target, CSF mutant huntingtin. We had a number of exploratory clinical outcomes which we included for safety monitoring. This was a 7-month study in a small number of stage 1 patients. We did not find, not surprisingly, any significant group-wise improvements or deterioration in the active group versus the placebo in a range of neurological and cognitive tasks. However, when we looked at the association between CSF mutant huntingtin lowering and clinical measures, there was a potentially interesting relationship. Here, up on the top left, is the total motor score change at day 84. And this is the change in mutant huntingtin at day 85. There was a significant association between lowering of CSF mutant huntingtin and improvement in the total motor score. Here is the simple digit modality task. That's a cognitive task. It's a bit like driving. There was a significant association between lowering of CSF mutant huntingtin and improvement in the simple digit task. There was no association with Stroop word reading, and a near significant association with the total functional capacity. However, this is a very blunt tool, and you can see here most people did not change over the course of the 7-month study, which is not unexpected. The composite UHDRS, which Scott is going to talk more on, is a composite of motor, cognitive, and functional clinical measures. We found a significant correlation with mutant huntingtin lowering and improvement in the composite UHDRS at 3 months. So, however, these findings are post hoc, they're exploratory, and they require replication and extension. And I must emphasize these are not markers of clinical efficacy. They are suggestive that mutant huntingtin lowering may be associated with clinical improvement, but this is not a marker of efficacy. So in conclusion, Ionis Huntington RX RG6042 was well tolerated at all doses tested. We got significant dose-dependent reduction in our target, mutant huntingtin, in CSF. When we started the study, we didn't know if that was going to be achievable. The magnitude of reduction exceeds the amount that's known to be effective in HD animal models with huntingtin lowering. And the data suggests that longer-term dosing will result in greater reduction. But as expected from the short duration study, we found no significant group-wise findings on our exploratory clinical measures. But a degree of mutant huntingtin lowering in CSF was associated with positive signals in a post-hoc analysis of several exploratory clinical measures. All of the subjects have been enrolled into an open label extension where they all receive the active drug. That's underway, and that will investigate the effects of sustained mutant huntingtin lowering. And planning is now underway for a longer, larger phase 3 study to demonstrate efficacy and long-term safety. And that clinical development program is being led by Roche, and Scott is going to announce that in the next talk. So for the families, no patients dropped out of the study. We had no serious adverse events in any drug-treated patients. It was safe in this 7-month study. It was well tolerated for the duration of the study, and we had dose-dependent lowering of our target, the disease-causing mutant huntingtin. And Ionis Huntington RX is no more. It's been handed over to Roche, who have the catchy name of RG6042. And now I'm going to hand over next to Scott, who's going to present the Roche program. So 4 years ago, I stood up here and presented the Ionis program, and Scott's going to present the Roche program. But before he pushes me off the stage, I want to have some acknowledgements. I'd like to thank the patients and families who participated in this study. When I presented the trial results at CHDI in early March, the patients who volunteered in September 2015, when we had no idea if this was going to work, be safe, be well tolerated, and those people who volunteered to be in the first-in-man study are the people I want to thank, because I wouldn't be here without them. And they are the true HD research heroes, and I really want you to give them all a round of applause. Who are all in the audience. I'd also like to thank Ed, who helped us with protocol development. I'd like to thank my Ionis colleagues, in particular Frank Bennett, Holly Kordevich, Anne Smith and Roger Lane, who've been amazing. My Roche colleagues, special thanks to Scott, Christian and Irene, and to the Roche team taking the program forward. And to our CHDI colleagues for partnership, and particularly Doug McDonald and Christina Sampao. And I'd like to thank you for listening.